This is a presentation to discuss COVID-19 and the life-threatening cardiac and cerebellar thromboembolic events that occur in cardiac operations. Here we present two patients who underwent major elective cardiac surgery. Both patients had false negative upper respiratory tract COVID-19 swabs. Initially, both patients were asymptomatic. However, later, SARS-RNA was detected by PCR in postoperative Broncho-alveolar Lavage. Both patients then went on to develop major life-threatening thromboembolic events. Elevated rates of venous and arterial thromboembolic events have been described among patients suffering from COVID-19. These include myocardial and cerebral infarcts, pulmonary emboli, macro and microvascular thrombi in lungs, as well as in other organs. These accelerated thromboembolic events may be due to many reasons. These include cytokine release during cardiopulmonary bypass, direct injury to the endothelial cells of the blood vessels by the virus initiating the clotting cascade, cytokine storm during COVID-19 infection, as well as intracellular reactive oxygen species in neutrophils as stimulated by the COVID-19 virus. Case 1 describes the presence of coronary and cerebral artery thrombosis in a patient who had a planned modified Bentall de Bono procedure. Pre-operatively, the COVID-19 swab was negative. However, after the operation, it turned out to be positive. This then required 2 emergency coronary artery bypass grafts as well as VA Ecma. The patient in question is a 52-year-old man, incidentally diagnosed with an aortic root and ascending aorta aneurysm. He initially presented to urology as he was passing stones via his urethra. There were no other significant comorbidities in this patient. The CT scan showed aortic sinus 47 mm, SJT 48 mm, and the proximal ascending aorta 48 by 59 mm. The transthoracic echocardiogram showed normal ventricular function with mild aortic and mitral regurgitation. In the aortic MDT, an aortic root and ascending aorta replacement was agreed upon. Before the operation, 2 COVID-19 swabs were taken. These were taken from the upper respiratory tract. One was 72 hours before the operation, and the second less than 24 hours before the operation. SARS-RNA was not detected by nucleic acid amplification tests. Additionally, this person did not have any symptoms of COVID-19. Pre-operatively, the coronary angiogram showed no flow-limiting coronary artery disease. The patient underwent replacement of his aortic valve, the aortic root, the ascending aorta, and reimplantation of the coronary arteries with a mechanical conduit carbosyl valsalva size 25 according to the modified Bentall de Bono procedure. The operation was uneventful and performed by an experienced aortic surgeon and classed as elective. Once the operation was completed, the standard dose of protamine, 300 mg, was given. This was to reverse the effect of the 40,000 units of heparin that was given at the beginning of the operation as routine. Blood or blood products were not administered as the patient was not bleeding. The patient was transferred to the ICU with a low dose of dopamine and noradrenaline with an FiO2 of 30%. A few hours later, the dopamine was stopped. During the next 12 hours, the patient remained hemodynamically completely stable. However, at 13 hours post-ICU admission, while still on the ventilator with a FiO2 of 30%, and with the plan of stopping the sedation to wake him up, he suddenly showed signs of deterioration. He became hypoxic, the oxygen requirement reached to 100% with a PO2 of around 8 kilopascals. He developed ventricular tachycardia, fibrillation and lost cardiac output. He required chest compressions with DC shocks 3 times. His circulation and cardiac output returned, but the oxygen requirement remained to 100% oxygen. An urgent chest X-ray was conducted which showed fully expanded lungs. There were no signs of a pneumothorax or a pleural effusion. We immediately inserted an IABP through the right femoral artery. The transesophageal echocardiogram showed hypokinetic inferior and lateral walls with impaired ventricles. The right ventricle was severely impaired. He was taken to the cardiology catheterization lab as an emergency, which was just next door to his ICU bed. An emergency coronary angiogram was conducted. The right coronary artery was dominant and included in the proximal vessel with an extensive thrombus. The circumflex was non-dominant, and the second marginal branch was occluded abruptly with an apparent thrombus. Cangrigol, a P2Y112 inhibitor, was administered. Angioplasty to the right coronary artery was attempted. Aspiration catheters were passed multiple times. Mechanical disruption was tried with a 2.5 mm balloon, and even the guide was manoeuvred to try and aspirate. However, the vessel could only be opened to the crux. Therefore, urgent transfer to theatre for a coronary artery bypass operation was agreed upon. The patient underwent an emergency CABG procedure. A full dose of heparin was given and cardiopulmonary bypass was established with the distal aorta and the right atrium. We decided to conduct the bypass grafts on a beating heart, without a cross clamp and without cardioplegia to avoid any further ischemia to the myocardium. The distal right coronary artery and the second obtuse marginal arteries were opened with small incisions. The clots were removed and the distal vein graft was anastomosed. The proximal ends were anastomosed with the aorta as per routine. The clots were removed from the distal right coronary and the second obtuse marginal arteries. Vena arterial Ecma was established. 2 arterial cannulas were passed using the Seldinger technique, a proximal for systemic perfusion and a distal small cannula for lower limb perfusion. This was through the left femoral artery and connected with the Ecma circuit with the Y connector. A venous return cannula was passed using the Seldinger technique through the right femoral vein. The patient was weaned off from the central cardiopulmonary bypass. His chest was kept open using the open chest management plan due to the severely impaired heart. Surprisingly, the patient was not bleeding. This was despite having received a full dose of heparin, whilst an earlier cardiologist had also given him cangrelor, a P2Y112 inhibitor. Therefore, we decided not to give him protamine to reverse the effect of heparin. He was transferred to the intensive care unit in a stable status on VA ECMO, milrinone, vasopressin, noradrenaline, and an IABP with an open chest. Later, continuous hemofiltration was started due to acidosis. Broncho-alveolar lavage was sent 2 days post-op. SARS-CoV-2 RNA was detected by the polymerase chain reaction. Through the next 3 days, the patient remained hemodynamically stable and showed signs of improvement. Moreover, he did not bleed. Therefore, his chest was closed whilst he was still on VA ECMO. His chest had been kept open for 65 hours now. Soon after chest closure, he had a CT head. The CT scan of the head showed multiple areas of acute ischemic infarcts in the right and left cerebral hemispheres, as well as the cerebellum. There was no acute intracranial hemorrhage or mass lesions seen. This was now 4 days post-op. After 5 days of ECMO, the patient was successfully removed from VA ECMO. In the subsequent days, he improved further and remained stable. All inotropes were weaned off. 10-day post-op, he had a tracheostomy. CVVH was stopped on the same day. He developed cognitive impairment as well as weakness in his limbs. However, he was able to move all 4 limbs to some extent. Later, his GCS improved up to 14. A CT scan of the head was done 13 days post-op. Bilateral cerebral hemisphere infarcts can be seen. There is no midline shift, uncal or cerebellar tonsil herniation. In the second case, we discussed how cerebral artery thrombosis in a planned aortic valve replacement was managed with neurodecompression. Similarly to the first case, the pre-op COVID swab was negative but came back positive after the operation. The patient in question is a 17-year-old female. She was born with a complex double outlet right ventricle with the subpulmonary VSD. She had a first operation at the neonatal age, where she underwent arterial switch with VSD closure and Lecomte maneuver. Her second operation occurred at the age of 13, where she underwent an aortic valve repair and left ventricle outflow obstruction relief. Later, she developed severe aortic valve regurgitation. The MDT recommended AVR and the patient was consented for tissue bioprosthesis. Prior to the operation, just as in the first case, the patient had COVID-19 swab tests. 2 swabs were taken from the upper respiratory tract, the second being less than 24 hours prior to the operation. SARS-CoV-2 RNA was not detected by nucleic acid amplification tests. Additionally, the patient did not have any symptoms of COVID-19. A third rediastenotomy with an aortic valve replacement was planned. This elective operation was undertaken by 2 experienced cardiac surgeons, congenital and adult aortic surgeons. It was an uneventful operation and the patient was transferred to the ICU in a stable condition. 8 hours later, the patient developed a seizure whilst on the ventilator. A CT scan of the head was done. It showed acute infarctions demonstrated in the right MCA territory. Broncho-alveolar lavage was sent 3 days post-op. SARS-CoV-2 RNA was detected by PCR. 4 days post-op, a CT scan of the head was done. There was diffuse bilateral infarction of the cerebral hemispheres in keeping with progression of an acute stroke. The patient was transferred to the neurosurgery intensive care unit where she underwent neurodecompression. 8 weeks later, she was self-ventilating with the tracheostomy tube removed. She started talking and she was eating and drinking normal food. She developed some cognitive impairment as well as weakness in her limbs. However, she was able to move all 4 limbs to some extent. There are a few important points that must be noted in these cases. In the first case, prior to surgery, the patient did not have any symptoms of COVID-19, and the 2 swabs for SARS-CoV-2 were negative. However, 2 days post-op, SARS-CoV-2 RNA was detected by the polymerase chain reaction in Broncho-alveolar Lavage. This is a case of a young man who had normal coronary arteries prior to the surgery, who then developed extensive life-threatening thrombi in his coronary arteries. He also developed multifocal cerebral and cerebellar infarcts. Importantly, the patient had a straightforward planned operation by an experienced aortic surgeon, and in fact remained completely stable for the first 12 hours. During the emergency CABG procedure, the patient had a full dose of heparin, and earlier he had also received cangrelor, a P2Y112 inhibitor. However, surprisingly, the patient did not bleed, despite not receiving any protamine to reverse the effect of heparin or any other clotting factors. In this second case, prior to surgery, the patient did not have any symptoms of COVID-19, and the 2 swabs for COVID-19 were negative. However, 3 days after the operation, SARS-CoV-2 RNA was detected by the polymerase chain reaction in Broncho-alveolar Lavage. Importantly, this elective operation was undertaken by 2 experienced cardiac surgeons, congenital and adult aortic surgeons. It was an uneventful operation, and the patient was transferred to the ICU in a stable condition. However, the patient developed extensive life-threatening thrombi in the right middle cerebral artery territory. Thromboembolism and COVID-19. Studies have demonstrated a close link between thromboembolism and COVID-19. One particular study on COVID-19 patients admitted in the ICU showed a 31% incidence of thrombotic complications. Studies have shown COVID-positive patients presenting with acute coronary syndrome due to thrombosis of the right coronary and left anterior descending arteries. One specific case showed a young man with COVID-19 pneumonia who developed an acute STEMI due to thrombosis in his left anterior descending artery. Another case study showed a patient with COVID-19 who developed an acute myocardial infarction due to extensive thrombus in her LAD. She developed cardiogenic shock, underwent percutaneous coronary intervention, as well as placement of a mechanical circulatory support device, but subsequently died from shock. Another case series of 4 patients has noted a greater incidence of stent thrombosis during the COVID-19 pandemic. In another case, a symptomatic COVID-19 patient developed an acute myocardial infarction due to a left anterior descending coronary artery in-stent thrombosis event. Venous thromboembolic events have been described among patients suffering from COVID-19 in other studies. So the question arises, what is the pathogenesis of thromboembolism in COVID-19? There have been many different theories as to what the pathogenesis of thromboembolism is in COVID-19. One such theory states that the COVID-19 virus stimulates extracellular neutrophil traps in a process called netosis. This is in association with increased levels of intracellular reactive oxygen species, also in neutrophils. The ROS-NET pathway then plays a role in thrombosis. Another theory states that the COVID-19 virus directly infects immune cells and dysregulates the immune system. It infects endothelial cells and damages them, activating leukocytes to potentiate a procoagulant state via the release of intravascular tissue factor, platelet activation, netosis, and inhibition of anticoagulant mechanisms. The presence of the COVID-19 virus within the endothelial cells suggests that direct viral infection induces the inflammation of the endothelium, as well as the host inflammatory response, which may further contribute to endothelial injury. A cytokine storm in COVID-19 is associated with a high mortality rate. Cytokines are known to be mediators of inflammation and immunity. They modulate the recruitment and activation of leukocytes, activate platelet aggregation, bind to endothelial cells, immobilize leukocytes, resulting in vascular occlusion and thrombosis. A raised CRP in a positive patient can either indicate the severity of disease, or it could simply just be due to recent extensive cardiac surgery. However, even patients with mild forms of COVID-19 remain at risk for COVID-19 associated coronary and cerebral thrombosis and coagulopathy. So what is the role of thromboprophylaxis therapy in COVID-19? For example, arterial thromboembolic events were also noticed in 9.6% of admitted patients with severe COVID-19 infection. Surprisingly, 50% of these patients were taking thromboprophylaxis therapy, 10% were on treatment dose of anticoagulation, and 25% were on antiplatelet therapy. Currently, a randomized clinical trial called DICER is investigating dipridamole in patients with confirmed positive infections to assess if it is effective in reducing blood clots. There are numerous reports from across the globe that indicate COVID-19 causes thromboembolism and can result in myocardial and cerebral infarction, pulmonary embolism, macro and microvascular thrombi in lungs and in other organs. However, these complications have not been reported widely. There should be a high index of suspicion of thromboembolic events if the condition of the patient unexpectedly deteriorates. Quicker diagnosis of COVID-19 will help management plans, especially in cardiac surgery. The question arises as to whether bronchio-alveolar lavage should be carried out routinely to test for SARS-CoV-2 immediately post-intubation for those patients who had recent negative swabs. The question is, will this alter the management strategy? If the result is positive and available prior to the start of the operation, surgeons will still have the opportunity to postpone non-urgent or non-emergency operations. If a positive result is obtained during or after the operation, the post-operative management strategies should be tailored on an individual basis to avoid major life-threatening thromboembolic events. Antiplatelet therapy with or without a prophylactic dose of anticoagulation can be considered at very early post-operative hours in SARS-CoV-2 positive patients. However, further evidence is needed to support this strategy. Thank you for listening to this presentation.